Well, that approach is usable when the new intervention is an alternative to something old. But I'm thinking of, for example, urinary dialysis, which was a completely new intervention. There is nothing that would have replaced when urinary dialysis was first introduced.
Right. In that sense, yes, that specific substitution, and there isn't always identifiable thing that can be displaced. But I was thinking of the budget as a whole. And if we think of our healthcare budget, as we add in more new activities, some activities have to drop out. So it may be that we're going to spend more on cancer drugs, and it's not other cancer treatments that drop out, or cancer screening programs or diagnosis programs, but it's spending on mental health goes down, or spending on dermatology goes down. So I was thinking not so much we have a specific health problem and what gets displaced. I'm thinking of the broader health budget.
But then you have to think about how much cutting this current budget increases.
That's right. That's the challenge. So this is the principle that we want to consider what it is we're having to give up when we adopt new activities. And so we need to have an estimate of what's getting displaced and the cost per quality of what's being displaced. Now that's no simple task, but conceptually perhaps it's quite appealing, because it means that as we take on board new activities, we're doing it knowing that we're producing more health benefit from our resources. To do the opposite, to take on new activities and for health benefit to shrink as a consequence, is very unappealing.
My question related to this issue is the relationship between the acceptable cost for a particular technology and the overall budget. So, should we consider cost-effective threshold independent of the overall budget in principle, or we may think about the budget and then determine the threshold?
Right. I think that's a very good question. And slightly anticipating what I'm going to say, but I'll say it. The problem of affordability and cost effectiveness is a problem because there's no mechanism to make sure they agree. If they agreed, if everything that was cost effective we could afford, life would be very easy. Now, there's two solutions. One is, if we're identifying more things that are cost effective and our budget's not big enough, you could say, well, we need a bigger budget, because there are lots of good opportunities for the health service, and it's not just health services, it can be public health interventions as well. There might be many opportunities to get additional health benefit. So the argument might be, we should therefore adjust the budget upwards. The other interpretation would be, given our budget, these interventions appear to be cost effective, they appear to be good value for money, but actually they're not. That we've set the threshold too high, and we should lower our threshold. And as we lower the threshold, fewer of these new activities will appear good value. Fewer new activities will appear cost effective. And we could bring the cost effectiveness threshold down sufficiently that affordability and cost effectiveness match again. Those are the two options. There really isn't any other option. Now, it's probably easier to adjust the cost effectiveness threshold than it is to be adjusting budgets. But over time, of course, the government might decide we do want to spend more in the health sector because there are these good opportunities, maybe with advancing technology, there are these good opportunities to acquire health benefit that didn't exist before. It could go the other direction. Increasingly, shall we say, we're having to work very hard to get additional health benefit. And we have to be country specific here. In wealthy countries such as Japan and England, we have to work quite hard in terms of new technology to make an appreciable difference to people's health. Not the same at all in poorer countries. We've done all the easy things, if you like. We're left with really tough health problems, which it's great that, in this campus, there's research scientists, doctors, clinicians working hard to improve health and find the next new molecular entity or new drug or redesigning programs to be more effective. But it's really quite difficult to find any, what we say in English, low-hanging fruit, easy things. The easy things have all been done. Now, in many much poorer countries, there are a lot of easy, basic healthcare interventions that could be done to get the benefit. But in countries like Japan and England, we are getting to a stage where we're having to pay quite a lot for additional benefit. So you could indeed say, well, maybe we're spending too much on healthcare. It's not a popular viewpoint with politicians, voters, patients, pharmaceutical companies, but maybe we just pushed it too far. We should spend on other things.
And I believe the actual situation in Japan is like the latter option. Actually, the budget is determined. And in this case, my question is the relationship between drug pricing and the assessment of cost effectiveness. If, in the case of a new drug, if a pharmaceutical company or the government reduce the drug price, then the cost will be lower than the previous assessment, and the product may be, meets the threshold. So, should the assessment of cost effectiveness be done independent of drug pricing?
Right. That's a very interesting question. Should the assessment of cost effectiveness be done independent of drug pricing? Well, increasingly, the manufacturer is doing an assessment of cost effectiveness and is thinking, what price can I charge and perhaps people will still buy my product because my new drug works this well, so I can charge this price. Or it works really well, I can charge a higher price. Many governments are then almost doing the reverse. They're saying, well, you tell us and you give us evidence that your drug works this well. Given how we value benefit, it's our threshold, the most we'd be willing to pay for your drug is this amount. So that is definitely happening from both sides. It's happening from the sort of governmental third-party payer perspective. It's happening from the manufacturer's perspective. And the price really is central to the cost effectiveness. It's obviously, or I hope obviously, not the only element, because particularly in pharmaceuticals, there's a lot of other healthcare activity that involves resources as well. But yes, the price is a major determinant of cost effectiveness. And arguably, countries that use cost effectiveness thresholds, that use economic information in their decision making, whether they're going to accept or reject new drugs, arguably they get better prices. And this is something that, I don't want to cause offense, but Donald Trump, although maybe he's popular in Japan, I don't know. Anyway, let's not go there. He has become very concerned about drug prices in the United States. And a couple of reports government reports have been issued, one by the Council of Economic Council and another by the Department of Health, arguing that prices are so high in the US because of all these nasty governments elsewhere around the world are driving a really hard bargain with the pharmaceutical industry. And they're saying, we won't buy your product at that price. Now, the criticism that the US government is making has an element of validity because, of course, a very high share of the research and development costs, particularly of new pharmaceuticals, is being borne by the US system. And so the argument is that governments in other countries are what's called free riding, are taking advantage. They're happy to see the new drugs developed, but they're not paying for the development, and then they're driving the price down in negotiation. There's a little element of truth in that, but anyway, slight aside, but yes, definitely, drug pricing and cost effectiveness have to be looked at together, and it's an important topic. Yeah, so I get carried away and go off in tangents. You have to stop me. Yeah, so as I say, just to summarise this bit, there are a range of sources for cost effectiveness thresholds, but really perhaps the approach that's got most satisfactory reasoning behind it is this idea: what's the cost per unit of benefit that will be displaced? Because if we keep our focus on that, that should ensure that we don't start doing new things that mean we lose health rather than gain health.